Usually when we talk about a medical diagnosis, there's this expectation of clinical precision.
Oh, for sure.
Like engineering, right? You break your arm, the x-ray shows that jagged white line, and the doctor just points at it and says, yep, there it is.
Right. It's binary, it's broken or it's not broken.
Mm-hmm.
We really like things to be visible and, categorized neatly.
We do. But welcome to the deep dive, where today we are stepping into a world where that x-ray machine is basically broken.
Yeah.
We're looking at a diagnostic landscape that is honestly incredibly murky. We are talking about pelvic floor health and specifically stress urinary incontinence.
Is the absolute definition of diagnostic muddy waters. I mean, truly.
And that is our mission today. We are digging into a massive stack of medical guidelines, urology studies, and clinical questionnaires to answer one highly specific question.
Right.
Exactly how do doctors determine whether stress urinary incontinence, or SUI, is categorized as mild, moderate, or severe?
Just to establish our baseline here, when we say SUI, we were talking specifically about the involuntary leakage of urine due to physical exertion or increased abdominal pressure.
Okay.
So we're talking about coughing, sneezing, lifting heavy objects.
Yeah.
This is fundamentally different from urge incontinence, which is that sudden, uncontrollable, nervous system-driven need to go, regardless of what you're doing physically.
Right, so it's a mechanical issue, an anatomical pressure issue.
Exactly.
And whether you are a medical student cramming for boards, a healthcare professional looking to refine your assessments, or, someone navigating these very symptoms yourself, understanding the exact metrics used for this diagnosis is huge.
Absolutely.
Because it empowers you to navigate the medical system effectively and actually understand what your doctor is writing in your chart. Okay, let's unpack this.
Let's do it.
Before a doctor ever pulls out any equipment or orders a scan, they start by simply asking the patient about their daily life, right?
Yeah, the foundational layer of grading SUI severity is entirely symptom-based. It's really about figuring out precisely what level of physical activity triggers the leakage.
Okay.
And in the sources we reviewed, two classic clinical scales come up over and over again for this: the STAMI classification and the Engelmann-Sundberg classification.
Let's start with STAMI, because it kind of feels like the grandfather of these systems.
It does, yeah. The STAMI classification breaks the severity down into three very practical grades based on abdominal pressure.
Okay.
So grade here, which is considered mild, is when urinary incontinence occurs with a sudden general increase in abdominal pressure. Think coughing, sneezing, or maybe jumping rope.
High impact stuff.
Exactly.
Because if we think about the mechanics of a sneeze, your diaphragm forcefully contracts downward. It essentially compresses all your internal organs like an accordion, right?
Right.
And that massive spike in pressure pushes directly down on the bladder.
And if the pelvic floor musculature, the hammock of muscles supporting the bladder, if that cannot dynamically counteract that sudden spike in pressure, the urethral sphincter yields, and you get a leak.
Makes sense.
Then you have grade 2, which is the moderate category. This happens with only a mild increase in abdominal pressure. So a patient might leak simply from sitting up from a chair, standing, or just walking around the house.
Oh, wow. And then grade 3?
The grade 3 is severe. This is defined as urinary incontinence that occurs regardless of physical activity or position changes. It just happens without any obvious provocation.
Looking at this, it really makes me think of a structural leak in a house.
How so?
Well, grade in the 3rd is like having a roof that only leaks during a severe Category 5 hurricane, right? Like a massive sneeze or a heavy cough.
Right, a huge stressor.
Yeah. And then grade 3rd is a roof that starts dripping during a standard everyday rain shower, like just walking around the living room.
Oh.
And grade 3rd means water is coming in just because the house is standing there, even on a sunny day. The structural integrity is just completely gone.
That analogy perfectly highlights why this symptom-based approach matters so much in clinical practice. It maps the physiological defect directly to your lived experience, and your mobility.
Right.
Because the jump from grade 1 to grade 2 fundamentally alters how a person moves through their own home. A grade I leak might be manageable for someone who doesn't do high-impact sports, but grade 2 requires a completely different treatment path because it impacts basic daily functions.
Right. You can't just avoid walking.
Exactly.
Now, you mentioned a second scale earlier, the Engelmann-Sundberg classification. How does that compare?
It's slightly different in its specific examples, but very similar in spirit to STAMI.
Okay.
So Engelmann-Sundberg grade CERT involves leakage from coughing, sneezing, and laughing. Grade 2 includes lifting heavy loads, climbing stairs, and walking. But their grade 3 adds a really interesting anatomical nuance. It's defined as leakage when standing, but not when lying down.
Wait, really? Now that is fascinating. So posture changes the internal mechanics that much?
Oh, absolutely. Think about the physics of the human body.
Hmm.
When you are standing upright, gravity is pulling your intestines, your liver, your entire visceral mass downward.
Right.
All that weight is resting directly on top of your bladder and pelvic floor.
Where?
But when you lie flat on your back, that weight redistributes horizontally across your spine and back muscles.
Oh, I see.
The downward mechanical pressure on the bladder is physically removed. So if just standing up, merely resisting gravity's pull on your own organs is enough to overpower the sphincter, that indicates a severe deficit in the support mechanism.
That makes perfect sense mechanically. But, I mean, here is where the diagnostic waters get murky for me.
Okay.
These are all highly subjective narrative experiences.
Yeah.
If a doctor wants to do a research study or, track if a surgical treatment is actually working over a 6-month period, stories don't fit neatly into a spreadsheet.
No, they don't.
They need hard numbers.
And that need for hard data brings us directly to the standardized scoring indices. We transition from descriptive grades to actual mathematics.
Right.
And the sources highlight two major tools for this: the Incontinence Severity Index, or ISI, and the CAPI classification system.
Okay, let's break down the ISI because looking at the questionnaire, it is brilliantly simple. It's literally just 2 questions.
Two questions that give a remarkably accurate statistical picture of the patient's burden.
Okay.
Question 1 asks about frequency, assigning 1 to 4 points. You get 1 point for less than once a month, 2 for a few times a month, 3 for a few times a week, and 4 points if it happens every day or night.
And the second question.
The second question tackles volume. How much urine is lost each time?
Okay.
You get 1 point for drops, 2 points for small splashes, and 3 points for more.
Right.
Then you multiply those two numbers together, frequency times volume. This gives a final score between 1 and 12.
And how does that break down?
Those numbers categorize the severity. A score of 1 or 2 is slight, 3 to 6 is moderate, 8 or 9 is severe, and a perfect 12 is very severe.
Okay, but I have to push back here a little bit.
Go for it.
Even with points and multiplication, isn't it incredibly subjective to ask a patient to differentiate between drops and small splashes?
Yeah.
Like, how does a doctor know if my idea of a splash is the same as your idea of a splash? I might be highly anxious and categorize a drop as a splash, while someone else might downplay a major leak out of embarrassment.
This raises an important question, and you're absolutely right to challenge it. The subjectivity is the fundamental flaw of any self-reported questionnaire.
Right.
But here is the critical clinical context. These questionnaires aren't primarily designed to compare you to me.
Oh, they're not.
No, they are fantastic for tracking a single patient's progress over time against their own baseline.
Ah, I see.
Yeah, so if a patient comes in with an ISI score of 9, undergoes physical therapy or surgery, and 6 months later their score drops to a 2, the doctor knows definitively that the intervention worked for that specific patient's perception of their problem.
Okay, that makes a lot of sense. But the ISI is just frequency and volume. What if we want a broader picture? Like, does any scale factor in things like how many pads a person is going through or if there are other anatomical issues at play?
That is exactly where the CAPI system comes in. CAPI is fascinating because it's modeled after the TNM system that oncologists use for tumor staging.
The TNM system, I'm not sure everyone is familiar with that one.
Right, so in oncology, TNM stands for tumor node metastasis. Instead of just saying a patient has grade 3 cancer, doctors score the size of the tumor, the involvement of the lymph nodes, and the spread of the cancer individually.
Oh, wow, so it's very specific.
Exactly. It creates a highly precise composite profile. And CAPI does the exact same thing for incontinence. It's an acronym.
Okay, lay it on me.
The S stands for stress-related leakage.
Yeah.
E is for emptying ability, like can they fully empty the bladder. A is for anatomic, evaluating the physical support structures. P is for protection, meaning their daily pad usage. And I is for instability, tracking urge symptoms.
That is comprehensive.
It is. And each of those individual factors gets graded on a scale from 0, 0, meaning no symptom, up to 3, which is severe.
So it's a composite score, but again, because of the subjective variation in how people report their own symptoms, urologists cannot rely solely on questionnaires for absolute diagnosis, right?
Exactly.
They also rely on strictly objective physical tests. Which brings us to what might be the most surprising part of the research.
Yeah.
It's funny, you'd think in the era of robotics and high-definition MRI machines, we'd have some sort of microscopic internal sensor for this.
You really would.
But the clinical gold standard for objective measurement is essentially weighing incontinence pads on a digital kitchen scale.
It sounds incredibly low-tech, But measuring the exact grams of urine lost removes all the narrative fluff. It gives you hard physics. And there are two main ways to do this,
Right.
the 24-hour test and the 1-hour test.
Let's start with the 24-hour test. This one is done at home.
Right. The patient is sent home with pre-weighed pads and instructed to live their normal daily routine. They go to work, they exercise, they watch TV.
It's a regular day.
Exactly. They collect all the pads used over 24 hours, seal them in airtight bags so none of the moisture evaporates,
Oh, smart.
and bring them back to the clinic to be weighed on a highly sensitive digital scale.
And what are the clinical cutoffs for severity on a 24-hour test?
Losing between 4 and 20 grams of urine over the whole day is classified as mild. Moderate is 21 to 74 grams. And severe SUI is defined as losing greater than 75 grams of urine in a 24-hour period.
That's a significant amount of fluid over a day.
It really is.
But if a doctor needs immediate data or wants to standardize the physical activity so every patient is doing the exact same thing to eliminate variables, they use the 1-hour test in the clinic.
Yes. And the International Continence Society, the ICS, has a very strict standardized protocol for this 1-hour clinic test. It's highly regimented.
It sounds like an obstacle course, honestly.
It basically is. The patient starts by drinking 500 milliliters of sodium-free liquid in under 15 minutes.
Okay.
Then they rest for a bit to let the kidneys process that fluid into the bladder. After that, they have to walk for 30 minutes, which includes climbing up and down a flight of stairs.
And it doesn't stop there. They have to stand up from a sitting position 10 times, cough vigorously 10 times, run in place for 1 minute, bend over to pick objects off the floor, and this one got me wash their hands in running water for 1 minute.
Yeah, and washing hands isn't just about hygiene there. The auditory cue of running water can actually trigger the detrusor muscle in the bladder.
Wow.
The entire sequence is intensely provocative by design, testing every possible mechanical and sensory trigger. At the end of the hour, the pad is weighed.
And the cutoffs for that.
The traditional, long-standing cutoffs dictate that 1 to 10 grams of loss is mild, 11 to 50 grams is moderate, and anything over 50 grams in that single hour is severe.
Here's where the literature gets really interesting, though, because the sources reveal a massive debate brewing in the urology world about those 1-hour cutoffs.
Oh, this is a very hot topic among researchers right now. They are finding a serious discrepancy when they compare the 1-hour test to the 24-hour test.
Okay.
Basically, the 1-hour test is consistently underestimating the severity of a patient's incontinence.
Why is that? I mean, if they are doing all those jumping jacks and coughing fits on a full bladder, shouldn't that trigger way more leakage than just sitting at a desk during a normal 24-hour day?
You would logically assume that, but consider the psychological and physiological environment of the clinic. The 1-hour test is highly artificial.
Right.
The patient knows they're being tested. They might be anxious, and subconsciously their pelvic floor muscles might be defensively tense and guarding the whole time.
Oh, I hadn't thought of that. Also, everyone's renal system works at a different speed. That 500 milliliters of fluid might not have fully processed into the bladder yet, depending on their individual kidney function. In contrast, the 24-hour test captures the reality of muscle fatigue at the end of a long day. It captures the unexpected sneeze when you're carrying heavy groceries and your guard is down.
So the real world breaks down the pelvic floor more effectively than the clinical obstacle course.
Exactly. Because of this dynamic, one major study in our sources analyzed the optimal threshold for the 1-hour test and determined that the traditional cutoffs are way too high.
Wow.
They suggested redefining them entirely, proposing that less than 3 grams should be mild, 3 to 10 grams should be moderate, and anything over 10 grams on a 1-hour test should be classified as severe.
That is a massive shift. From 50 grams down to 10 grams for a severe diagnosis. It really highlights how medical standards are constantly evolving as we get better data. But wait, I have to bring up a specific nuance from the reading that caught my eye.
We are talking about grams of weight. A single paperclip weighs about a gram. It's tiny.
It is an incredibly light measurement, yes.
So if someone is doing a 1-hour test, climbing stairs, running in place, I mean, they are going to sweat.
Naturally.
How does a doctor know if a tiny 2-gram weight increase on a pad is mild urinary incontinence or just sweat from the workout?
That is a very real clinical problem. The sources note a highly specific threshold for the sweat and discharge factor.
Okay.
It is generally accepted in the medical community that a weight gain of less than 1.4 grams in a 1-hour test or 4.4 grams in a 24-hour test might not be urine at all. It could easily just be sweat or normal vaginal discharge accumulating over time.
So what happens if a patient comes in, does the test, and the pad is exactly 1.3 grams heavier? Do they just guess?
Medical science has a very colorful, practical solution for that. If the findings are inconclusive and hovering right around that sweat threshold, doctors administer an oral medication called phenazopyridine.
Orange pill.
Exactly. It safely turns the patient's urine a bright, unmistakable fluorescent orange.
That is amazing.
So if the pad gains 1.3 grams of weight, but the fabric is completely white, it's just sweat. If it's 1.3 grams and glowing orange, you have definitive visual proof of a mild urinary leak.
I just love how pragmatic that is. You have doctors debating highly complex statistical thresholds for diagnostic criteria. And at the end of the day, solving the mystery comes down to a digital scale and a pill that dyes your pee orange.
Practical medicine at its finest. But as objective and useful as the pad test is, it has one major limitation.
What's that?
Pad tests tell you exactly how much fluid is leaking, but they do not tell you why. They measure the volume of the symptom, but they offer zero insight into what specific anatomical structure is failing inside the pelvis.
Right. To figure out the why, doctors have to actually look inside. Which brings us to clinical observation and videodynamics.
Yes, we move from measuring volume in grams to observing internal mechanics in real time. There are specific visual grading systems used during these exams, often done with a full bladder and a cough test.
The Schisler and Elose classification in the notes seem very visual.
It is purely observational. The doctor literally watches the urethra during a cough test.
Okay.
Under this classification, grade the first is when they observe mere dribbling while the patient is standing, but no leakage at all if the patient lies down.
Right.
Grade the second is a steady stream of urine when standing, but again, nothing when lying down. Grade third is severe gushing urine while standing and gushing while lying down.
It circles right back to that gravity and internal organ pressure concept we talked about earlier. If removing the weight of the intestines by lying flat doesn't stop the leak, the system is fundamentally broken.
Exactly. And to truly understand why it's broken, doctors use fluoroscopic imaging videodynamics. They put contrast dye into the bladder and watch it on a screen under X-ray while the patient moves and coughs.
Wow.
The gold standard for grading this physical failure is the Blivus-Olson classification.
Okay, let me try to visualize this based on the reading, because the anatomy gets a bit complex here.
It does.
The Blivus-Olson looks specifically at the bladder neck and the intrinsic sphincter, the internal valve. So type 1 is mild. The valve is closed at rest, but with a cough, the bladder base drops a tiny bit, less than 2 centimeters, and a leak occurs.
Correct.
Type 2 is rotational descent. The whole bladder and urethra significantly rotate and drop down into the pelvis when the patient coughs, pulling the valve open.
Yes, exactly.
So if the bladder drops in type 2, then type 3 must mean the support hammock completely snapped, right? Like a totally torn muscle.
Well, not exactly. It's actually not about the hammock snapping or tearing. Type I and type 2 are hypermobility issues. The support structures allow too much movement under pressure.
Okay.
But type 3 is a completely different mechanism, and it represents the most severe anatomical failure. It's clinically known as intrinsic sphincter deficiency, or ISD. In type 3, it's not that the bladder drops when you cough. It's that the bladder neck and the proximal urethra are fixed open at rest.
Wait, fixed open at rest?
Even when the patient is just lying there, completely relaxed, not coughing, not straining, not doing anything, the internal sphincter muscle has completely lost its resting neurological and muscular tone.
Oh, wow.
It is hanging open like a rusted pipe. There's no resistance barrier left. The only thing keeping the urine inside is the physical angle of the urethra.
If we connect this to the bigger picture, this is a massive paradigm shift in the patient's condition. A type I or type 2 patient leaks actively. They have to sneeze or jump to create the pressure that forces the urine out.
Exactly.
But a type 3 patient leaks passively. The door is already open. The fluid just spills out from normal everyday existence.
And doctors measure that deficiency mathematically using a metric called Valsalva leak point pressure, or VLPP.
Okay.
They fill the bladder, ask the patient to perform a Valsalva maneuver, which essentially means bearing down, as if they were having a bowel movement, and they use a tiny internal catheter to measure the exact pressure inside the bladder at the exact millisecond the urine escapes.
So they are measuring the precise breaking point of the valve.
Exactly. If that breaking point, the VLPP, is less than 60 centimeters of water pressure, that is the urodynamic threshold that often defines severe intrinsic sphincter deficiency.
Less than 60.
Yeah. A healthy valve can withstand a massive amount of pressure. If it gives way at under 60, the internal resistance is severely compromised.
It's just wild. We've journeyed from asking someone how many times a week they sneeze and leak, all the way down to measuring the precise internal water pressure required to breach a compromised anatomical valve.
That journey highlights why there are so many grading systems. No single test tells the whole story.
Right.
You need the subjective ISI to understand the patient's lived burden, the EuroPI to map the full clinical picture, the PAD test to prove the physical volume, and the urodynamics to identify the specific anatomical failure.
So what does this all mean? Why does knowing these specific criteria, STAMI, ISI, 24-hour pad weights, Blevis-Olson, why does this matter to you, the listener?
It matters a lot.
It matters because it bridges the gap between what you experience alone in your bathroom and what your medical chart actually says. Knowledge is translation.
Absolutely.
If a patient knows they are losing over 75 grams of fluid a day, which we know is severe by the PAD test, but they're only experiencing it when they do heavy CrossFit, which is grade I by STAMI, understanding these conflicting grading systems helps them have a much more informed, precise conversation with their urologist. They can advocate for a treatment that fits their specific mismatch of symptoms and mechanics.
It protects patients from being dismissed, honestly. If you can confidently tell a doctor, my frequency and volume put me at an 8 on the incontinence severity index, that demands a totally different level of clinical attention than simply saying, I leak sometimes.
Right.
It turns a murky subjective complaint into a hard clinical metric.
Before we wrap up, let's look at the horizon. We've talked about kitchen scales, paper diaries, and orange pills. Where is this technology going?
We are on the verge of a massive leap forward.
Yeah.
We currently rely on patients manually logging their activities or weighing physical pads in Ziploc bags.
Yeah.
But as we move into the era of smart fabrics and wearable biometric tech, the landscape is going to change entirely.
You're talking about smart underwear.
Imagine a day, likely very soon, where biometric smart underwear continuously and precisely transmits leak volumes down to the fraction of a gram, simultaneously paired with exact abdominal pressure data from a smartwatch or fitness ring,
Oh, wow.
sent straight to a doctor's smartphone in real time.
That would completely render the 24-hour pad test and the orange dye obsolete.
It would give us continuous real-world urodynamics without the patient ever having to step foot in an obstacle course clinic.
And suddenly, that broken x-ray machine we talked about at the beginning of the show, it doesn't just get fixed, it gets upgraded to high-definition video. The murky waters clear up, and millions of people finally get the precise, undeniable validation they've been waiting for.